Okay, hello everyone, and welcome to the third and final webinar in our series exploring the topics highlighted in Embracing Complexity's Top 10 Priorities for Research on Neurodivergence. My name is Georgia Harper, and I'm Policy Manager at Autistica. We are thrilled to have you here today for what promises to be an insightful and impactful discussion on improving services for neurodivergent people and the massive difference that basic adjustments can make. Today's webinar will take a slightly different format than usual. It's basically an open panel discussion. We've got 5 brilliant panelists with us today to share a range of perspectives on service provision. It's being chaired by Helen Neal, a neurodivergent counsellor who has worked with us closely over the past few weeks to put this panel together. Our other panelists today are Jax Blunt, a late diagnosed autistic adult with ADHD, and Oliver McGowan, co-trainer / expert by experience. Lou Greenfield, an occupational therapist and autism assessor in an NHS autism diagnostic service. Tom Moore, a senior commissioning manager for Surrey County Council's Adults Wellbeing and Health Partnerships, where he leads on autism. Joe Plum, an autism support trainer who is co-leading the Autism Friendly Community Surrey project for Autism by Experience in partnership with Surrey County Council. And hopefully joining us later, Dr. Janine Robinson, a consultant clinical psychologist and national specialty advisor for NHS England. So without further ado, let's dive into today's discussion. Over to you, Helen.
Thanks very much, Georgia, and thanks everyone on the panel as well for making time to do this, and also extending that thanks to all of you that have turned up and potentially given up some of your lunchtime to be with us as well. So we're obviously focusing on the concept of changing sort of services and helping to make them more accessible for neurodivergent people. So those small changes that can really make a big difference. So one of the things that has struck us is the factors that might be shaping professional attitudes and behaviours towards neurodivergent people within those systems, such as training and media narrative. And considering those factors, how might we overcome these? So that's the question to the panel to start with.
I think for me, there's something about the history here. We've got a historical situation where, if you go back far enough, and it's not even that far, where autism was sort of a male condition, a male neurotype, and now we're in a situation where, thank goodness, we've realised that that's not the case, and anyone of all genders or no gender can be autistic. And I think that shift has been really important. But actually, we're still seeing the overhang of that. We're still seeing ways of doing femininity and ways of being autistic, and where they sort of intersect, not being picked up. And I think can be very harmful in a diagnostic setting. So we might see situations where someone's special interest it's a very typical interest in terms of how society might deem a little girl to experience the world. But actually, the way that she's experiencing that is autistic in quality. There's a monotropic focus. There's a real intensity to the way that interest is being consumed and lived out, but it's being missed because it's quite typical, so to speak. So I think those kind of gender aspects are still potentially being missed in diagnostic services. And actually, if something's being missed in a diagnostic service, there's potential that it's also missed on the ground in services that aren't diagnostic services. And those are the services that are often we hope are picking up autistic traits and then sending them over to the diagnostic service. So I think that's really, really important. I think the other aspect that we're not necessarily potentially, and I'm thinking sort of globally, in terms of the NHS, we're not necessarily picking up on the masking aspects of autism. And I think we're not necessarily always the best at saying, okay, you've described this experience, tell me more. You've described X, tell me what that feels like for you in your head, tell me how you experience that. And that's often where you get that little layer of, well, actually, yeah, I do this, but underneath that, this is all the effort that I'm putting in on a day-to-day basis to present in this sort of typical way, in this sort of neurotypical, so to speak, kind of manner, really. Yeah, I don't know if anyone else wants. Yeah, I can see there's a few hands up, so I'll be quiet for a second.
So thanks so much for that, Lou. It sounds like you feel that there's those societal expectations, and particularly around the neurodivergent presentation, alongside that the masking that we obviously have to do to function within society, and that can have a detrimental effect because it means that things are missed, particularly alongside the fact that the diagnostic criteria are obviously built on males. And I noticed that Jax was going to say something initially, Lou, and would you like to have a chat now, Jax?
Yeah, sure. I mean, agree with a lot of what Lou's saying there. We also need to remember about ethnicity. We historically have a lot of underdiagnosis if people aren't white, because a lot of the original research was little white boys. So if you aren't little white boy, you can't be autistic, and we all know that's very, very wrong. But there is still that tendency to think that if you don't fit that stereotype, you can't be autistic. We've got a lack of good training that's updated to all of these things. So some of the training that's still happening is still very outdated. It still relies on a lot of these old stereotypes. We've got media narratives about overdiagnosis, about people getting diagnosis really, really easily, and all of that devalues lived experience. And the way that we combat all of this is that we've got to center neurodivergent voices, stories, but not just the usual suspects, if you like. It's got to be actually reaching out to the people who historically aren't heard from and lifting their stories and lifting their voices. So the intersectional stories, the ethnicity, the gender overlap, all of these things, we've got to be pushing and giving these people a platform. And that's how we change professionals' attitudes and behaviours. That's how we overcome the misconceptions. That's how we make a change for all neurodivergent people. Yeah.
Thanks very much for that, Jax. It very much resonates, the sounds of giving us more of a voice within the spaces that we need that support. And I guess I'll bring Tom in on anything else, particularly as I know that they have done a considerable amount of work around communities within neurodivergent and autistic spaces.
Yeah, I mean, I think Lou and Jax have really covered a lot of it. But I think, you mentioned training at the beginning, and I think that for training to be effective, when we've got these new narratives that are a bit problematic that are out there, it feels like we've moved on from some old problematic narratives. There was the kind of refrigerator parenting, or it being a middle class condition, those kinds of things. It feels like we've moved on to those, but we've got some new ones that are equally problematic in different ways. But and the overdiagnosis one, I think, is key, and the idea that people learnt it off TikTok, or TikTok, or everybody's autistic nowadays. It's the training, who it's coming from, I think really makes a difference. So the fact that it is autistic people putting the message across about their own experience, I think makes it so much more powerful than just someone going through training content. And I think there's other narratives within services that, those are kind of public narratives, but there's narratives within services that I think sometimes are about that need challenging too. Sometimes they're about only a specialist autism service can support autistic people, or a special, neurodevelopmental specialist service, rather than an expectation that this is everybody's business. We're all part of a wider population, and we all need to have access to the support and the services that we're entitled to. And And I think there's sometimes narratives that take hold within services that are about gatekeeping, because services are tight for resources. And so I think there's a almost instinctive reaction from people. Geez, is there someone we can say no to here? Let's find a reason to say no. And I think that bit, hearing from people's own personal experiences, I think is really powerful with that as well, because people don't come into services in order to be mean to other people, or to people come in to try and make a difference and to try and help. So I think there's, that's, to me, that's the job of the training, to try and challenge those and get people to a better, more realistic understanding.
Yeah, thanks for that, Tom. And it's changing that narrative, but trying to ensure that we don't get new and, again, incorrect narratives coming into it because of some of the concepts that are driven within the media. I noticed Janine's hand came up when you were speaking, so I'm wondering if she wants to jump in on that as well.
That's great, thank you. And I'm so sorry I was late. I may have missed some points that I'm going to repeat, hopefully not. But really, just I think Tom mentioned some very particularly important points, I think, around services, around training, because I think there's training on its own isn't going to make a difference. You as an individual clinician practitioner may well be able to make a difference in your interaction with one particular person, but unless that's it, there's that sense within your service, your team, that yes, everybody matters, and yes, we're not particularly set out to support autistic people, but let's try and make a difference. And it's actually of benefit to our service, it's of benefit to a whole host of people. It becomes, and so what otherwise? If we said, let's train more people, let's make sure the training's up to date and is covering the breadth of the spectrum, of course, that's wonderful. But unless you have system change, I think that becomes a kind of, we're preaching to the converted then. And I think we said this once before at one of our meetings, everybody in the room was probably the sort of person who was trying to make reasonable adjustments and trying to think about the other person and thinking about systems, but it's how do we get other people to do the same? And I think what Tom says was also right in terms of, whether you're working in a diagnostic assessment service where there's enormous pressure, to working in other organizations, other sectors, not just the NHS, there's a huge amount of pressure. And if there's the case of the combination of pressure, maybe lack of understanding, maybe also the lack of a sense of competence. If there's an area that you don't feel confident in, so competent in, it's probably easier to shut that down. But people kind of need reminders of, actually, there is the Equality Act and you should be doing this, and it is everybody's business. I think we kind of need those sorts of reminders. And it's interesting, in my own area, we've started a few years ago a neurodevelopmental discussion group where it's really great because it means it's becoming much more in the organization, a sense that this is shared. Yes, the autism team is doing the chairing of it, but everybody's learning from each other. And there's a sense that if you're working in psychosis, or you're working in eating disorders, or you're working in talking therapies, you will all have your own developing expertise of that particular presentation that person has when they're coming into an early intervention psychosis service or perinatal mental health, etc. We can all become specialists in our own way and share, rather than that sense of, yep, that's one for the autism team. So I think there are ways in which we can help develop that sense of competency and confidence across services and across sectors. But it really is a system-wide thing and an expectation that needs to be had, I think, as well. So that's enough for me, I think.
Thanks very much, Janine. And so it sounds like you feel that though we can make those changes ourselves at that local level, it is really also about that collective voice to help to change the systems that we also operate in. And I noticed that Jo has her hand up, so I'm wondering if she would like to add to that discussion.
No, it was going back a bit, actually, to what may partially have been covered about the knowledge of autism is outdated, perhaps, and whilst services, some areas of services are increasing their awareness of autism, they haven't actually had the training to update their knowledge. And I've certainly come across attitudes where it's considered that if an autistic person can make or if a person can make eye contact, they can't be autistic, which is obviously very outdated. So I think there's a great misunderstanding because the knowledge is outdated, and that's why it's so important to have the training from autistic people, from co-produced training and delivered by autistic people to bridge that gap.
Indeed, and that training is I guess doubly important because we need to be looking at the whole of that neurodivergent space as well, and thinking about autism, ADHD, dyslexia, dyspraxia. 90% of autistic people also struggle with their sort of dyspraxia, and often it is not given as a standalone diagnosis. So there is a perhaps a sort of a focus maybe within the neurodivergent community sometimes on one or other rather than whole, and that connectivity is I guess also really important, and I suppose that actually does bring me on to the next question that I have for my own personal experience. One of the barriers is that I am ADHD and autistic, and that presentation in itself can be very confusing. I make eye contact, I am quite chatty, and that has caused a barrier for myself within these systems and in particular the healthcare service, and I'm wondering if that resonates with others, and anyone else has faced any barriers or resistance to making some of these small accommodations in the services that you have accessed, and if you have any advice for clinicians and also individuals that are experiencing that. Hi there, Tom. I noticed your hand come up there.
Sorry, talking on mute. Yeah, just quickly, really. But I think there is something in terms of barriers that people have talked to me about finding in services, to do with understanding, to do with recognizing, a lot of what we've talked about already. And I do think that one of the ways of overcoming it with services, to address that kind of gatekeeping approach, is to make the case. And sometimes we need to make it formally, and sometimes we can just make it in a conversation, but to make the case that it is not only the right thing to do in human terms, but it's actually cost effective for services. It's resource efficient in services to understand where someone neurodivergent is coming from, to understand what they might need from a service, and to be able to meet it, to adjust the service to be able to come and meet the person where they're at. So it's just that, really. It's that's my little bit. That's my tuppence worth. I'll back.
Thanks very much, Tom. And Jax, did you have anything to add to that?
Very much agreeing with you on the co-occurrence thing. I think I'm right in saying that when I was diagnosed as autistic, it wasn't actually possible to be diagnosed as ADHD as well, because that's a relatively recent change, DSM-5, I think. And I think I was just before that cutoff. So I then, having gone through most of my life feeling like a failed human being, and then discovering that I was autistic, I then spent several years feeling like a fake autistic person, because we're told that autistic people are organised and structured and require routine and certainty. And I have ADHD as well, raging ADHD as well, and I live in chaos. So I felt like a failed autistic after having been a failed human being. And it's only in the last year, since I've got the ADHD as well, that I'm really starting to unpick all of the everything. And the fun of it is when you get the ADHD medication, it kind of tamps down the ADHD, and then the autism can come out full flow. So it's a constant balance. And I know people think that sometimes we're faking things for attention. I wish that I could just push all of this away and do things normally. And the effort that it takes to mask, to pretend, to present, to try to do the things that people expect, to get the responses that you need and the support that you need, it's exhausting, it's soul destroying. And the reason I show up for webinars like this is to make a change so that other people don't go through it. But yeah, the complex presentations where you've got the additional layers of neurodivergence, entirely possible that I may have some strands of dyspraxia. Pretty convinced one of my kids does. How would I go about getting that diagnosed? It's been an absolute battle to get to the autism and get to the ADHD, and we're still battling to get any support following getting the diagnosis. Shouldn't be so hard. Once somebody gets even one assessment, let's try and make sure that we're covering all the bases, picking up the related things. It would be cheaper. It would be cheaper if we caught people early on instead of waiting till they were in crisis to try and pick them up. So small adjustments can one service signpost into another one, even if it's literally just a leaflet saying all of these other things might be relevant too. Yeah, small adjustments. If you have an assessment, can a summary come out afterwards? Because too often appointments happen in one place, they disappear into a system, and you can't access the details of what you talked about. Now, I can't always remember what I talked about, you know? So small adjustments give us better information, help us be a part of the journey. Yeah, but absolutely signpost to all the different things that might be relevant, and stop with the silos. Stop with the gatekeeping. Stop with the you're in this box so you can't be in any other. Actually, we might be in lots. Yeah. So yeah, that was my little rant for the day.
Thanks very much, Jax. And it sounds like the acknowledgement that being neurodivergent may mean that there are multiple neurodivergences. And actually, we don't want to have 3 years waiting for an autistic assessment and then 4 years for an ADHD one, and then the realization that you might be dyslexic and so on. And by the time you get there, you're 75 and it's completely chaotic. That's not what we're after, obviously. Thanks very much. And Lou, I noticed your hand up, and I'll come to Joe and Janine in a moment.
Yeah, just a quick one to respond to what Jax was saying about the kind of the coexisting nature of autism and ADHD, and obviously, as we know, they heavily overlap but don't always get on, so to speak. And in one of the things that we do in our service, and every autism diagnostic service will be different, and there's lots of pressures on our services that are all different, but one of the things that we do is when someone gets added to our waiting list, unless there's a really clear clinical reason not to, and usually there isn't, we will offer everyone a brief phone call with a clinician where we explain about the service, and we find out about just the general overview of kind of what the support needs might be at the moment, and signpost people. So we're allowing people to be signposted before they sit on our waiting list, and no one's waiting list is short, and that's part of the reason. But one of the other things that we do is we have it in our kind of almost our script for that triage, is we hold this idea of autism and ADHD being cousins and being related. And we're thinking about people's language during that triage. We're thinking, has this person also identified something that might be a hinting at potential ADHD profile or potential something else as well? And if it starts to come out in the triage, we might run the ASRS, so the adult self-report scale that kind of is sort of checking for ADHD symptoms during that triage. And one of the philosophies of this is that quite often people come and they have an autism assessment, let's say they get a diagnosis, and actually at the end of that report, a number of ADHD traits were also reported. And what we're doing is potentially saving someone 2.5 years, 3 years, by getting that information at that date. Now, it is a privilege to be able to offer that, and a lot of services won't be able to offer that, just in terms of how things are commissioned and things like that. But just to say, that is something that that we do, and it's, I think, whether a service can offer a triage is dependent on the service and funding and pressure and constraints. But what potentially could be done is just considering whether any potential ADHD is coming through in the referral form, and then maybe suggesting that client consider further analysis, not necessarily consider an assessment, because it's really hard to predict whether someone should have an assessment from a referral form, but that they might want to go and read up and think about it for themselves, because that might save that 2.5, 3 years. But again, it's hard. It depends on the service, and there's so much sort of constraint because we have so many people on our waiting list. Yeah.
Thanks, Lou. That sounds like a simple, small adjustment that might be more complex to implement depending on the environment within the assessment services. So hopefully that's something that the guys on the call can take away. Jo, did you have anything to add?
Yes, I was very fortunate in that I was diagnosed with ADHD before I was diagnosed as autistic. And I didn't have a huge weight between the two. And it's interesting that on our team at Autism by Experience, out of 12 of us, almost all of us have a dual diagnosis. But what is very difficult is that very few of us had any post-diagnosis support for autism, and I don't think any of us have had any help for ADHD. So trying to understand how the two interrelate is incredibly difficult for us. We've had some training quite recently on it, because we're now delivering training on how the two relate to each other. But I think to expect professionals to understand it, if we find it very difficult to understand, is it's almost understandable that they find it difficult. So I think we should be asking them to have an open mind and to believe what we're saying rather than dismiss what we're saying, because I think the attitude can sometimes be to be just quite dismissive of what we're saying, because it doesn't quite add up in their minds. I also am incredibly chaotic, which doesn't fit with the autism profile, but that isn't necessarily recognised by a professional. So I think just to ask for an increased awareness of what this dual diagnosis or several diagnoses can bring.
Thanks very much, Jo. And just to say that resonates with me as well as an autistic ADHD, and I was diagnosed ADHD, and I'm on a wait list for autism, and I live in what my other half sometimes describes as organised chaos, which is a desk that is a complete mess, but I actually still know where that pen is. And that might just be me, but that's also the kind of the difference in presentations, because everybody is different, and it's about listening to that individual experience. So thanks very much, Jo. Janine, I noticed you were about to say something too.
Yep. There we go. It isn't what I was going to say, but just Joe's very useful comment. I thought I'd pick up on that first and then make the point I was going to make. I think, Joe, it's really interesting because my own service is commissioned only to assess autism, even though obviously we very often will see, a bit like you said, we'll see people who probably either have characteristics of ADHD or maybe they already have a diagnosis. But there is something that we've talked about quite a lot in terms of would somebody who's autistic and also has ADHD confirmed or possibly benefit in the same way for the psychoeducation that's offered generally for people who are autistic. What about people who are getting an ADHD diagnosis and an ADHD service, but they might be autistic? There's something about what might work and what might need to be done to support those individuals who maybe have both in terms of that post-diagnostic bit. And I wonder if there's some learning that's to be done. So there are jointly commissioned ADHD and autism services, and I'd be really curious to know, how are they supporting people afterwards? So that might be something to think about in the future, as in, is there something where, I don't know, if somebody who's got an ADHD diagnosis but perhaps is also autistic but wasn't diagnosed by the autism team, are they able to access that support, for example? But it does feel like there's some missing links there, and maybe there is some room to do a bit of learning from where it is happening already. And we know obviously that in Wales and in Scotland, services are much more commissioned as neurodevelopmental services, covering a whole spectrum of conditions, not just autism and ADHD. So are there things we could be learning from other systems that could perhaps make some differences? Maybe not so small, maybe actually bigger differences, but nonetheless, that's the first thing. I suppose fundamentally, also just going back to Lou's point, these are some of these are system related issues, which could, if accepted at a commissioner level or at a provider level, really make a difference to those services and that individual practitioner, clinician trying to make a difference. So, for example, in my own area, we were establishing a patient and public involvement group, but trying to set up a payment scheme took almost a year. Now that seems to be really unfortunate that for a team that's really keen, is absolutely saying we really need to hear from autistic people who've been through our service as to what improvements we can make, how can we co-develop the post-diagnostic offer, etc., to then not be able to do what you want to be able to do and think is right in terms of paying people for their time and respecting their contributions properly, including being able to have a session to feedback, this is what difference it made, you're participating in the service. Seems like those kinds of obstacles are really unnecessary and unhelpful. We did eventually get it done, so that's good. But it's the sort of thing where, we happen to obviously be a service where you understand all of those issues, so you can leverage a bit, but there'll be other groups that won't be able to do that as well. So I think that's really important. One of the other bits that probably I imagine other autism services have as an issue, but equally other healthcare systems, services, and could be education, could be local authority, etc., is estates. It's rooms, buildings, spaces, and how can you make it understood in your service and to your system that actually we need a space where the alarm isn't going off all the time. We need a space where people can actually sit in a quiet space, the lights aren't too bright, and so on. Those are really small things potentially that could make a huge difference. Rather than sitting in a room apologizing to somebody coming in saying, sorry, I can't switch off the lights, or sorry, I can't change the temperature in the room. So those are things that can make a massive difference from the outset, and then being able to advise individuals or ask them ahead of time, are they happy to be in this kind of a space? How would they like to be seen? And so on. But at the moment, I think many services are having to just apologize for the fact that there's not a lot they can do. So there is something about recognition at the sort of estates level of how that can make a huge difference to people accessing services. So
Thanks very much, Selena. It sounds like there's a question there, I guess, for facilities and estates around having more flexibility in the environments that we're operating within some of these systems as well. I've noticed a little bit in the chat around some of the thoughts and ideas about post-diagnostic support that you were talking a little bit about there, Janine, and I've getting the feeling from what people are saying in the chat that the post-diagnostic support is not really readily available. I'm wondering if anyone would want to speak to that, about maybe how we can start the process of change and make some small adjustments there that might make things sort of easier, in inverted commas, once we have that diagnosis. So I'm happy to start. My post-diagnostic experience was basically a cliff. And I don't know if that resonates with others. I'm also a counsellor, so I probably coming from a place where it is a little easier to access support because of my experiences as a counsellor. And the thing that for me would have been really beneficial would have just been really something simple, like maybe a little leaflet that said, this is the ADHD support group. This is an up-to-date website with some useful information, because some of the stuff that I have been signposted to in the past is really out of date. And social media channels, because that is a way of communicating now, and perhaps we would do well to embrace some of the information that is on there that is actually really beneficial, and peer support as well, of course, which has been really helpful for me within my profession. I have found my own peer support networks, and that is actually something that perhaps you can do some research about peer support within your profession or within your local area, and within your local authority to get that experience and support post-diagnosis, so you really don't feel like you just walked into a void. I noticed Jax raised her hand after I started talking, so do feel free to jump in.
Yeah, I'm being amused by some of the comments in chat with what was it, succinctly described as a diagnose and dump system. Yeah. So I was diagnosed as autistic. I have 4 children. They're all diagnosed as autistic. They've been diagnosed through different routes at different times. The first one who was diagnosed was then passed to a kind of local multidisciplinary assessment unit, and there was assessment, there was OT assessment and advice around that. There was speech and language assessment and advice around that. There was behaviour. We were having behaviour challenges at the time, and there was advice and support, very bad advice and support, but there was advice and support around that. Then my next child was diagnosed and was too old to be referred to that particular assessment unit, and there was nothing. There was nothing. I was diagnosed and I got a nice big informational pack with leaflets, including the stages of grief that I was supposed to be going through. Thanks for that. I'm not quite sure what that says about getting a diagnosis. And that was pretty much it. But then they ran a set of kind of group therapy sessions almost. And I think the idea was that they were trying to build us into a peer support network. But you can't stick 6 people in a room who the only thing they've got in common is that they're late diagnosed autistic, and expect that they're going to build a social network over the course of 6 sessions where they're being taught how to breathe through their ankle to relieve stress. It was nonsense, and it didn't help at all. And most of the support that I've found has been via the social media networks that you're talking about, and connecting with peers going through what I'm going through, and then becoming one of those people who's a little bit further down the line and trying to give other people support. The more we can do to build those networks, to give people the access to other people who've gone through it, and the less we dismiss that. So I've seen pushback from experts on social media networks, ironically enough, talking about the misinformation that's out there. The misinformation is out there because the information isn't accessible. So support people to find the information, support them to develop the networks, but also listen to what they're saying, because if they're saying it for a reason. And even if it's not accurate to the diagnostic criteria, it's often something we're still going through, and therefore it's not misinformation, it just doesn't fit your medical model. Yeah? But those experts are the ones that get the platform.
It's I guess it's this individualized focus again, isn't it? That people might generalize on social media about something they're experiencing and suggest that everybody experiences that. That doesn't make their experience less valid. It means that we're needing to speak more of the wide variety of experiences that people have within these neurodivergent spaces. So thanks very much, Jax. Janine. Oh,
Sorry.
yeah, I think you're on your mute there.
I'm off mute. Hang on, let me just lower my hand too.
Thank you.
You know what? I have now forgotten what I was due to say. And in any event, I think Tom was before me, and hopefully by that stage I'll remember why I put up my hand.
Not a problem at all. We all have that. Tom, would you like to say what you were going to?
Yeah, sure. So just in summary, so we're working through our an all-age autism strategy.
Sorry, Tom, that there's an echo in the background. I don't know if you've got two windows open, because there's pretty awful pitchy eared feedback for a moment. Do you want to try again? Maybe just
Is
check.
that okay?
That's it. I think that's better now.
I was struggling to get into the Zoom earlier, so I did actually have two windows open. You're right.
Okay, do you carry on? I think it's left now. I think it might. No, there is still some feedback, Tom. Let me go back to Janine.
Okay.
And then we'll come back to Tom, because I think she's remembered what she was going to say.
Absolutely. No, that's fine. I think these issues about not knowing where support is and how to access things after your assessment, I think they're really, really important. And I suppose if I think about my role within NHS England, one of the things that we suggested and recommended in our guidance that we published back in 2023 was that each area should have in their footprint information that's publicly available, both for the public but also for referrers, for people at any stage of the journey to know, where do I go for this? If I'm a parent and I'm thinking I might want my child to be assessed, if I'm an adult and I've already got a diagnosis and I've moved from another area, how do I know where to go, where to get information, where to get support, whether it's local authority, whether it's peer support, whether it's statutory type support, and so on. And we've suggested that sort of transparent information is made available and kept up to date. And that includes things like, if you decide you don't want to wait that long for your local assessment because it really is very long, and you're going to uni and you really want an assessment, actually, what is the path? What are the options if I go down this right to choose method approach, or if I go down and I pay for it privately because I can afford it or my parents can afford it, then what happens? Actually, I don't have access to support locally because I've made a decision to go privately. People don't always know what their options are and what the repercussions are and the consequences of making those decisions at that stage. And we've come across some areas where they've actually built up really nice online portals which does exactly that, being able to signpost where would you go at different stages of your pathway and your journey to be able to get support, to get information. Because one of the problems I know in my own area, we had a really lovely kind of resource pack. But obviously, 6 months' time, that particular resource is gone or it's changed names. And then, the resource pack's, no longer valid and so on. So if there's a way in which there's something sitting there that's accessible, it's really important that you, as a referrer, for example, also knows actually, because we get this sometimes, we get an individual coming for an assessment saying, well, my GP didn't want to refer me because he said, what's the point? There's nothing out there. But actually, maybe the GP doesn't know that there's a lot out there in terms of supporting people at different stages of their journey and for different types of support. And bearing in mind, at the point of getting the diagnostic outcome, you may not need something right then, or you may not feel ready. But 6 months' time or a year's time, you might need something. And it's really important to educate both referrers as well as other services you might be in contact with, and then you yourself as an individual, or if you're a parent and so on. So that was one of the pieces of recommendation that was made in that NHS England guidance, because I think that would help address. I mean, obviously, there's still going to be areas where there isn't a lot of support and resource out there, but pulling it all together, I think, is a huge start. And then you'll be surprised to be in those discussions, in those rooms where you find that somebody working in children's services has no idea of what's available for adults, and yet they'll be working with young people who'll be transitioning into adult services and so on. So I think that becomes a really important exercise in regions. So that's all I wanted to say.
Thank you, Janina. It sounds like it's going back to Jax's point about silo, but across individual sort of services within the NHS, and improving that communication between those services. I also think there's a point to be made very briefly, and Jax has pointed it out in the chat, about the language that is used. And you obviously mentioned, Jax, your experience of this is the grief that you are going to go through. And the concept and idea of being neurodivergent affirming, and not positioning neurodivergence as a tragedy necessarily. There are challenges, there are impairments, and they all need to be acknowledged, and the difficulties that brings, but not then doing the opposite and saying that this is a wonderful superpower and you should now be really happy about it. It's getting that balance right, and that affirming language that acknowledges the difference without minimizing the experience, and that feels really important within any communication too. So thanks for that, Janine. And Tom, you were going to say something, and then I think we're probably going to go into our 5-minute break, and then take the questions from the chat, because we've nearly hit the hour.
Great. Is that sound better? Is that not doing the
It does,
feedback?
yes. Thank you so much, Tom. Yes.
Right. Okay. Good. So just thinking about post-diagnosis, I mean, and agreeing 100% with Janine, where where do you bring information together? And just to say where that's happened in Surrey. So we've got an autism partnership board. We've got one for adults and one for children, but we're quite closely linked. The Adults Autism Partnership Board been going for a long time, and we recognise this was kind of common feedback that people felt diagnosed as an adult. What now? Where do I find information about what's possible and what's available? So we have put something up on our web page that we've added to over time, and when we put it up, I have to say it was scant. There wasn't a lot in there, but it's kind of built up over time, and I think it's actually a really helpful resource. And so just to say, where does that come from? And I think part of it is, so we've got this autism partnership board. It's autistic people, it's and family carers, and multi-agency professionals from lots of agencies, and the web page is hosted by the local authority, and so there's somebody who's actually got time. I think that it's kind of crucial that there's who's going to actually do it, because even if it's not a big job, who's got that much spare time to actually sort of host a web page and make sure it's up to date, which is, because they do go out of date, things go out of date very quickly. So there's that, and that has kind of supported and built alongside work that Joe's doing. And I hope that Joe, I don't want to put Joe on the spot at all, but I hope Joe gets a chance to talk about the autism friendly communities work that her organization are doing, which very much is looking to, the autism strategy has got a few little peer support groups going here and there. The autism friendly communities work, as part of what they're looking to do next, is very much looking to expand that and grow that. So I almost think having the information and doing the doing of it are kind of quite closely related. If somebody's doing the doing but nobody's got the information, it's not going to fly. And so yeah, I don't know. I thought I had that clearer in my head than it seems to have come out of my mouth. But
it sounds clear to me. The idea is that there is a need for the communication between the organisations and an idea to create these resources, but at the same time you need to have the infrastructure and the people to keep those resources going and to build those communities longer term, rather than not just have a small idea that then dies away because there's no one updating and contributing.
And crucially, the sort of, we need neurodivergent people to be having input in that. So if we put up information to say, oh, this is where you get support, and it's actually rubbish, it's no use to anyone, then we need to know that and to be able to change it. Equally, we might not know about something that's going on, and so it needs to be networked and people working together, basically.
Yeah. So, Joe, did you have something to say there? I noticed your hand go up.
Then I realised we're going to lunch, so
it's fine. It's only 5 minutes, so it's not a problem. If you want to do it now, that's absolutely fine.
I was just going to add on to what Tom was saying, that indeed we are working with Surrey County Council and are developing this peer network and using the social media channels to do this, and workshops for neurodivergent people. And we believe very, very strongly that it's the peer networks that are so lacking. And in the absence of the post-diagnostic support, I think the peer networks are going to be what people rely on, because there's nothing else there, or very little else there. And I think it's going to really pull together. We've been working on it since, I think it was March, and it's showing strong signs of taking off quite quickly.
So it sounds like you're using the social media networks to actually reach out to neurodivergent people and bring them to your spaces, and potentially also online discussions, if I've got that wrong. So it's face to face as well as.
Yes, we haven't run our workshops yet. We've got a couple of workshops coming up in July, peer consultation workshops, to find out what people want and to tell them where we're at. We've got quite a large number of autistic people, neurodivergent people on our mailing list, the people that have signed up already. So we'll see what the outcome is of that, and hopefully get more ideas of what people actually want. But the social media channels are going very well.
Just to go to some of the questions that have come through, there's been a couple of them actually around the inequalities within the community, sort of resonating with what Jax was talking about around intersectionality, and one in particular around the inequalities around the community of people of colour, and someone saying that those people don't necessarily understand the condition and are rarely believed by professionals. So do anyone within the panel have any tips on engaging those voices who are quite often left unheard? It sounds like Tom would like to speak to that.
Yeah, I'd just say so in Surrey, there's an organisation called Surrey Minority Ethnic Forum, who are who I guess act as a voice for various minoritized groups of people, and they've been we've worked with them as the all age autism strategy to reach, because we did in the first year, maybe 2 years of the strategy, we were sort of looking at what had been achieved and had we reached the sort of the wider community, and we kind of hadn't fully. So working with, so I guess that the answer to the question is finding the networks that are there already, and talking to people and asking them about it. And when we actually, a few of us put on a couple of information events and workshops, and yeah, the with description in the question, that really rings true there. People either, some people understood the sort of conditions well, they'd researched and things, but a lot of people didn't, and also a lot of people did not at all feel heard. It was, most of the people who came were actually parents of school age children and didn't feel heard in their children's schools. So there was a lot, I think, and then once that's aired, you can kind of, that can become part of the work, that is how do we address this within the system of services kind of thing. So yeah, but what's worked in Surrey has been going to already organised groups. Oh, Helen, you're on mute.
Yeah, I'm on mute. It sounds like it's looking for some of those already established networks and bringing the neurodiversity conversation to those networks. And I'm wondering about sort of the some of the cultural issues around neurodivergence and understanding across different cultures as well, and how that there is potentially a piece around education and training in many different cultures and different areas of intersectionality to understand neurodivergent conditions more. And perhaps social media can be involved there too. Sorry, you were going to say, Tom?
And I think that is really important, but it was just reflecting as you're talking, I mean, it was really useful for us as well to understand people's points of view, and maybe different ways that people who came to those sessions thought about what was going on with their children, and interpreted it, and interpreted what what they wanted from services, and what they thought was the job of family, for example, was perhaps different from other groups that we'd talked to. So there's definitely two-way learning.
So it sounds like that there's an area where we all need to learn from each other. Okay, Janine, did you have something to add there?
Yeah, just very briefly, and I see somebody's also popped something. Jack, so you've put something in the chat. I think it's an interesting area, and I think partly this is why there is a little bit of research going on at the minute around stigma, and how do you address that within a range of communities, because I think it's not only minority ethnic groups where that will be the case, but I think it's important to generally get a sense of why is it that people are anxious about what a diagnosis might mean for them, their child, etc. I think the other bit that's interesting is there's been some research around identifying children's needs within an education system rather than a health, in the sense that perhaps there might be particular groups who will say, well, who won't feel they want to access health care or psychiatric services or anything like that, but actually education, if the school picks up that there's something different, this child is struggling in this particular domain, etc., that may be more neutral and maybe an easier way to access or bring in a family, for example, who would otherwise not be seeking a GP referral or anything like that. So it's about where might you find ways in with communities so that you can break down some of those barriers, and it may be through education, for instance.
So, it sounds a little like talking about support needs and understanding those support needs, as well as the access to the diagnostic services. Jax, did you have something to say there?
Yeah, unfortunately, the idea that schools might identify people of other backgrounds as needing referral to autism services, it in experience with people that I've known who've gone through this, it's actually worked the other way. Schools are less likely to refer to autism services and more likely to think of it as a behavioural or parenting issue if the family is not white. So perhaps there's need for greater information sharing into schools as well as into diagnostic services. Schools very often are kind of the front line of a lot of this stuff, but we're not doing anything to train up teachers about any of these things. So maybe that's an area that has to be addressed alongside everything else. Just a thought.
So, and I'm hearing there's something that in my training is more about self-awareness and our unconscious biases, and actually there is a need perhaps for that kind of training at some point to help us really understand what it is that we're doing within these settings and what those biases are resulting in terms of spotting some of these needs in our children and adults as well. Okay. Hi, Lou.
I was just going to say, I think I can sort of speak to a diagnostic service and how to kind of make things more sort of intersectionally affirming. And I think one of the things that we can do, and again, it's hard because we are swamped with referrals, but is allowing that additional time in an assessment for us as assessors who are not necessarily from that cultural background to try and understand that background from their perspective. And so, I'd just own it. I'm not from that background. Tell me about what that is like for you. Tell me, and if they're able to, tell me about what you know about the cultural norms in that situation, because it helps us to know what is a kind of norm, a social norm, and I mean that in inverted commas, in those backgrounds. But again, that's allowing space for us to have long enough assessments or assessments at different points of time so that we can do that. And then I think this is more of a systemic thing around the number of BAME people in the NHS, in social services, etc., etc. But that work around what are we doing to get more and more professionals and more workers in general from BAME communities who are going to be meeting these autistic people, and therefore having those water cooler conversations with people about, actually, I know these autistic people and this is how they present, and actually this is why I think their presentation might be slightly different. But that is a massive systemic thing that perhaps is outside the scope of this conversation, but I think is a big part of the long-term sort of improvement strategy here.
That I'm hearing that there are some small changes, but there are also some big changes that perhaps we don't have the time to address today. So I'll move on to the next question that we had within the chat. So this is a little bit longer. I manage one of the specialist services mentioned earlier and have noticed a recurring issue with diagnostic overshadowing. In our experience, other statutory or professional services often look to us to take on tasks that would typically fall within their remit. This seems to stem from a lack of confidence, skill, or resources in supporting autistic clients, particularly when it comes to co-occurring needs such as anxiety or mental health. Instead of addressing these as separate legitimate issues, they are often attributed solely to autism. As a result, some autistic individuals are deemed ineligible for the same support, such as NHS talking therapies, that a non-autistic person with the same presentation might receive. And they're asking, how might we begin to challenge and change this pattern across services? Now, obviously, that's a big question. So I'm thinking about some of those small changes that might actually be actionable based on the title of the webinar. And Joe, I notice you have your hand up here.
Yes, this is something that I feel very strongly about. I have bipolar, and was in mental health services for a long time before I received my autism diagnosis. And the moment I received my autism diagnosis, I was told that mental health services doesn't deal with autism. That's their words. And I was discharged, even though I was very unwell with bipolar at the time. And whenever I've had a relapse with bipolar, I've been I haven't had access to mental health services as a result of being autistic. I've been told it's your neurodivergence, which has obviously resulted in a lot more illness than I think I could have avoided. In terms of what can be done about this, I think that again it comes down to training, and I think it has to come from people people with lived experience of these co-occurring conditions. I think because I think only we can describe what it's like to have something like bipolar or anxiety or depression alongside autism, because I think to an outsider it might be quite hard to differentiate sometimes, and certainly in the space of a 20-minute appointment with a huge power imbalance, a huge amount of stress, it's impossible to argue against a psychiatrist who's absolutely set in his mind that it's your neurodivergence. So it has to come from training, from people that can speak up in a setting where there isn't that power imbalance.
Thank you very much for sharing that, Joe, your personal experience there. It sounds like that there is a need within mental health services, and you mentioned psychiatrists there, and in particular, of understanding how presentations can differ, and also there's an element here where we're attributing people's feelings and experiences to one thing and not the other, and actually isn't it really about supporting the needs of that individual regardless of where that is actually, in inverted commas, coming from. So and I have personal experience of this. My brother has been in mental health services with schizophrenia and is likely undiagnosed autistic ADHD, and that, you know, there's not enough time to go into that, but it's a very complicated process getting people to listen and understand, and to see the whole person.
Yeah.
So thanks very much, Joe. Tom, would you like to add to that?
Just saying on that, I mean,
You're feedbacking again. Sorry, my ears are going.
maybe I'll put it in the chat.
Okay, sorry, Tom. I don't know what you did last time. Maybe you could do it again.
I didn't do anything. I just waited and it went away.
Oh, well, it went away. Oh dear. Okay. Lou, you have something to add.
It's just a small thing, again, to thinking as a diagnostician or working within a diagnostic team, I should say. When a client is bringing up a history of anxiety, that's the classic one, a history of anxiety, and it might become clear that them being autistic might have caused a situation where they're vulnerable to bullying, and then they've had experiences of social trauma manifesting as as social anxiety. And in that situation, you can say that in the formulation, you can say it appears that that's the sort of mechanism here. But there's also going to be situations where someone has, like Joe has said, and like I think it was it Helen who wrote the question, said, there's going to be situations where there is a mental health condition that is sort of highly separate, and they may intertwine and sort of relate to each other at times, but actually they're completely different. And if you've got enough clinical reasoning around that achieved through the autism assessment, you can write that in the report, and you can almost preempt it. And actually that's going to give that person a piece of paper that is saying, actually, the person who assessed me and the team who assessed me for autism have diagnosed me with autism, but here's where they've said they don't believe that autism is the underpinning factor for an experience. Obviously, we have to be careful as clinicians as to how far we go with these formulations, because we have done an autism assessment and not a massive mental health assessment. But there are times where we can absolutely do that, and almost putting that preempting hat on of like, how might this diagnosis potentially in the wrong hands be used against someone, or be used in a way that's not conducive to them. So that's a small thing that when you're careful about your remit, you can do. But that also requires a certain amount of advocacy from the client and confidence to be able to go, here's the document. And that's something we don't have as much control about. Yeah.
It sounds like that is a small change to help with that systemic issue with this the siloed nature again, which is again something that is popping up quite regularly. I don't know, Tom, do you want to try again? Is it safe? Are my ears going to twitch?
You'll have to tell me. How's that?
That's fine now.
Okay. Well, I was just halfway through typing actually, but I'm not sure. I mean, I don't have a small change. What I was going to say was this resonates very strongly with experience in Surrey. A lot of people have had very difficult negative experiences with kind of diagnostic overshadowing and ignoring of mental health needs as a result. We've got, I suppose the small changes that have worked have been things like community preventative mental health organizations, where those people have taken on that realize that they're supporting a lot of neurodivergent people already, and sort of get so seeking some training, and they'll link with Joe's organization or others to sort of build that up. But the core issue of the clinical NHS services, we've had discussions and training has been put in place and all of these things, but that working culture feels very difficult to shift, and it doesn't feel like, probably it's only a Surrey thing. As I think people's experience in other parts of the country seem quite similar. And if anybody's got a magic fix for it, I'd love to hear it.
Sounds like there is a move to community support, both with the peer support network and also using third sector organisations potentially.
I think that's right, and I think that's really important. But I think stats. What was it? I think depending on what study you read, 70 or 80% of autistic people will have a diagnosable mental health condition too. Those people need NHS clinical support, when they need it. It needs to be, Equalities Act, yes, but it needs to be recognised and implemented. So, it feels like the idea is there, but the practice, perhaps it often isn't.
Yeah, it sounds like that there's a knowledge that we're still falling short. And from what Lou says, maybe that there is that small sort of change that you can make within those reports that enables an autistic individual to say, look, actually, this is the cause, and therefore I'm able to access mental health services.
Yeah, when I was typing it, I was saying that sounds fantastic. That's what I was going to say. That sounds like a really positive. It's a useful document for someone to have when they go and if they're batted back by a mental health service.
We only have a few more minutes for questions, so I'm just going to ask one more. If you were to, as panelists, and anyone can chime in here, if you were to change one small thing about your experiences as a neurodivergent person, that it was actionable, that could be done, what would it be? Jax.
Ask professionals to follow the Oliver McGowan ask, listen, do framework. Ask people what they need, listen to what they tell you, and do what they say. It's simple. Everybody can do it. Yeah.
That is incredibly succinct. Thank you very much, Japs. So that's an ask, listen, do. Okay. Anyone else have any thoughts? Lou.
So I'm neurodivergent myself, although I'm not autistic, and I think for me, and this is also drawing on what my clients have told me, autism assessment clients have said, is being able to appropriately, obviously, communicate with the assessor between assessments. So I will say to my clients, I understand that there may be things that you haven't brought up in the last hour and a half. That happens. And feel free to email my NHS email if anything pops up. And I will also, if there's also an potential ADHD coexisting situation, I might say, even if it's just one line, because you know you're going to forget it later, crack on. That's fine. Because a lot of people do worry about, are they going to get it out in the very short period of time that they have? And it can feel like an audition in a way. Just get it all out. And that can take a lot of the stress off. So I think that's quite a small and potentially easy to implement change.
Okay, excellent. Thank you so much. I'm thinking it's probably time that we pass to Georgia. My one thing is to, if you can, see the person sitting in front of you, not the biases that you might have about the neurodivergences, whether that's boys, they always really move loads, or what happens about the boy that's inattentive and ADHD, or you really just speak to and find out about that person that's in front of you, and set aside any unconscious bias that you have about your view of what that presentation is meant, in inverted commas, to look like. Okay, so Georgia, would you like to do the closing moments? Thank you so much to all the panelists for your time. Really appreciate each and every one, being here and taking the time to share your experiences and your expertise.
Brilliant, thank you. And that was a brilliant way to finish as well. It's, see the person in front of them and listen to what they're saying is, sounds really basic, and yet often doesn't happen. Yes, so we're coming to the end of today's webinar. Thank you all for all your time and engagement today. I've really enjoyed following on with the chat. Thank you so much to Helen for chairing the panel brilliantly, and to Janine, Jax, Joe, Lou and Tom for such an insightful discussion. Thank you again, and we hope to see you at our next webinar. Have a great day, everyone.